And I wanted to open it up to audience participation and questions. Yes, yeah. We have a few. If you guys want to stand, yep, go ahead, stand up. And yeah, if you want to walk to the center mic, that would be great. If you feel like you can project and we can hear you, that's also fine. What? Oh, sorry, you have to be at the microphone. Thank you. 5 minutes, great. So we'll do three rapid questions.
Yeah. Pat Hinton Walker, and I think you just touched at the end on the issues. Those of us that have been involved with nurse-managed care in communities for years have had all the same problems that you're describing. And I think one of the things that we tend to do, because I've done a lot of international work, we tend to take our models, even though they're broken, and try to put them in other places. And so you could describe everything that you've said about our healthcare system and the problems you're having there if we look at the history with nurse-managed clinics trying to serve underserved populations in an uneven environment.
Mm-hmm. Yeah, I mean, one thing that I think we should be when we approach the developing world is very humble. I mean, our science is top-notch, and we're sitting here in the National Academy of Sciences, and we've done amazing things with science. But everything else about our healthcare system is not so great, and so we should not be very willing to presume that we don't bring a lot to emulate when we go to many other places.
I'm Kate Lancome, the Director of Capacity Plus, which is USAID's Global Health Workforce Project. And thank you, everyone, for your presentations and comments today. I think this is a real opportunity for leadership for the national and the global health professional organizations to get midwives and nurses together, link them up with the funders, help give them the training, connect them to the mentors, drive the training down into the pre-service education. I also think that this type of private sector employment for nurses and midwives also helps make the health sector a lot more resilient. What we see in a lot of fragile and conflict-affected states is the public health system just completely falls apart. Or what we saw in Mali when there was the insurgency in the north, the health workers who were trained and working there, they were displaced with the people and continued to provide care, whereas the public health system just completely collapsed. And also to reflect some comments made earlier this morning, we have to put modules on opening your own business into nursing and midwifery pre-service education. As you said, it can't just be this game of catch-up. You have to build it into the pre-service education so they see themselves as entrepreneurs. They have a list of, what are the 10 steps to open their practice. They know who to call, and you really remove some of those barriers.
Yeah.
Thank you.
The only comment on the education piece, we're also seeing very exciting educational models where, and actually one of the modules of mobile-based education that we see a lot of is business learning. So banks are now trying to get mobile apps that they can give to their customers so those customers learn basic business skills. And that same type of thing could apply to the type of entrepreneurs we're talking about in this area.
Mm-hmm. Hi, my name is Björk Pelstetter. I'm from the Training for Health Equity Network, which is a collaboration of schools that are actually specifically trying to train health workers to work in disadvantaged areas around the world. And this has been a really interesting forum, and I think there's so much to learn. And we all know that this is complex and we need to work together. But one thing which I think would be really interesting to think about is in terms of, given that we've been talking about the dysfunctionality of this system, how can we actually apply some of these lessons to private interventions that are taking place, for example, in Rwanda? Because let's say in a lot of these countries, there's no capacity to do quality control, to make sure that there's necessarily a regulatory environment. How can we ensure that, like somebody said, that we don't sort of transpose dysfunctional systems into other countries, but actually learn those lessons and build in quality control mechanism and actually integrate them with education? I think that's something that we don't want to scale up the current educational models. They have to be much more dynamic. And I think it would be interesting also to think about what kind of education institutions do we need and what kind of competencies are now needed for these, to make these integrate education and service delivery, ensure there's continuous quality control, and that there's a dynamic system that continuously tries to meet changing needs.
Mm-hmm. I agree 100% with everything you said, and I would say that a lot of our education for medical health care dates back to the 19th century. And it's things that were done then that we now assume should be done, and we have to take a completely different view of how these things are done. But on the quality point, I want to talk about an example that Beth and I have both worked on, which I think takes this new model approach, which is something called Safe Care. And if you were to go around Africa and try and find accredited institutions, you know, the main accrediting body is the Joint Commission International. And I believe north of South Africa, there were probably 2, maybe 3 institutions that passed JCI accreditation. I mean, and of course it's a pass-fail system. So you could be almost there and you're failed and you're just graded just the same way as something that's nowhere close. So a group that Beth and I both work with created something called SafeCare, which they worked with JCI and the South African accredited agency COSASA to create, which provides grades. So instead of a pass-fail, you can move up the ladder bit by bit, and it recognizes its grades for resource-constrained settings. So it focuses on those things that really can be done in these environments, and doesn't, you know, insist that clinics do things that are impossible in many of these areas, and instead says, oh, you know, what's a workaround that would get the same result, but isn't necessarily what fits exactly what JCI would require. Now, the interesting thing with this is, once the system came into place, a lot of clinics said, this is great. Now you've told me that I'm at the bottom rung. To get to the next rung, I need some financing. Where am I going to get that? And that's what the Medical Credit Fund that the Calvert Foundation was one of the first investors in helped provide.
Thank you, and I think we're out of time, but thank you. Please join me in thanking John for joining us today, and thank all of you.